Thank you so much. And thank you really to the organizers for having us here and doing a physical meeting. It's nice to actually interact in person. So congratulations to the organizers on that. And that was a very lovely talk and we really enjoyed it. And, I hope we can ask you some more questions along the line. I'd like to invite my panelist, Dr. Anuj Gupta. He's Assistant Professor Medical Oncology at Varanasi. Dr. Rakesh Katna. He's head and neck and skull-based oncosurgeon at Leelavati, Mumbai. And Dr. Pavan Agarwal, who is our senior consultant at Bhagwan Mahavir, medical oncologist. Dr. Ankit Agarwal, I think he's not here. Is that correct? Online. Oh, okay, great. He'll be there online. Dr. Ankit Agarwal will be joining us online from Geetanjali Hospital, Udaipur, medical oncologist. And Dr. Tapaswini Pradhan, a senior consultant head and neck surgeon at Indraprastha Apollo Hospital, New Delhi. So I have a really eminent faculty over here. And I am in awe because I'm not really sure what I'm doing asking them questions. But we've been given a task, so let's go ahead with it. Basically, what I would like our panelists to touch upon is, everybody knows the standard of care and things like that, right? But let's talk about what we do in our day-to-day life, because at the end of the day, that's what's important, right? What we're doing in India and what we're doing in our practice and the challenges that every institution faces, because obviously not the same set of, I would say, expertise is available everywhere. So, kind of let's focus on some of those things. We all know that our Indian head and neck patients are extremely challenging and really what is so easy in the Western world may not be quite so simple in our world. And because we be focusing on locally advanced head and neck squamous cell carcinoma, I'll start with our surgeons because they're the ones who usually see the patients first. I mean, the medical oncologist comes really at the last. So how would you define, locally advanced head and neck cancer? And just because I'm going to touch the first patient will be borderline unresectable, we'll talk a little bit. Come back to you to talk about that. So just tell us a little bit about who you perceive as the locally advanced head and neck cancer case, which you're not going to jump on.
So it's a sad fact, actually, what we see in our OPDs in India, specifically almost 80%, it's more than 65% patients are in stage 4 only. So we'll label them as a locally advanced. Now in locally advanced, any patient who's like stage 3, stage 4 with neck metastasis, which we put in as locally advanced. Again, we categorize into 2 parts, generally when we see clinically also. Till T4A, this is a surgeon's realm only. So where the issue comes when it goes to T4B or the borderline resectability. So large tumors going on above the zygoma in the oral cavity, going to the parotid, going to the higher bone down, large neck nodes. So these are some patients where we are to think upon that, yes, we need the help of our other colleagues also, like from the medical oncology and other options for these patients.
Dr. Tapaswini, did you want to add something in, when you see these patients and what, I think probably when you see the patients and you're trying to delineate a treatment strategy before you're going to your MDT, what do you perceive as the challenges that your patient really faces? Because at the end of the day, whenever we talk about prolonging survival and everything, we also really in the head and neck patient, more than anything else, have to focus on quality. What are the, the problems, the functional problems that these patients really face?
Correct. So head and neck area, of course, is challenging because this is the part of the body which can never be hidden. So whatever you do, your results are absolutely open. So disfigurement is one major concern, and the other is the functional aspect of the area. So when we talk about advanced head and neck cancer, I think he has already enumerated, and it's primarily distributed as with the tumor primary and with the nodal. So in the spaces which has been classified by the AJCC, that it's clearly defined if the tumor goes to a particular space, to what stage does it move into. But the problem and the issues come when it is borderline. So if we have buccal mucosa, as he said, if the edema goes more high up into the zygomatic area, or if you have an infratemporal fossa involvement, which is a very high infratemporal fossa involvement again, or if there are lesions which are involving the skull base, to do or not to do, and how to, tailor make your treatment. And every anatomical area has its own challenge. If you're looking at a tongue which is going into the base tongue, coming close to the vallecula, or if the invasion has gone very close to the floor and invaded into the hyoid, or if you have cheek buccal mucosa, as we have already said, coming close to the zygoma. Larynx, if it's involving the tumor is coming very close to the carotid vessels or involving the postcricoid area. So many other, I think it's a well-defined realm, but there are situations where you are in a catch-22 situation where we call it as a borderline resectability. And nodes, of course, when it is N3 type of a node, and it is encasing the carotid vessels. Again, it becomes a tricky situation. It's surgeon to surgeon expertise, whether you can remove it or not, or even if it is salvageable a situation, whether it is worth it.
Exactly.
That's another
I think
thing.
that's a very important point to highlight over here, because especially in your borderline resectable or even the locally advanced buccal cancers, doing a huge surgery and then coming out with a positive margin or a closed margin, then, you know, all the effort you put in really becomes negligible. So that's where we all have to focus together as a team and work for the betterment. So let's look a little bit at the journey that these patients go through. And we know that there are, you know, depending on what aspect of the head and neck we are dealing with, there are strategies for functional organ preservation which have equivalent results, I would say, and in some places where they don't. So we'll talk a little bit about that. And we all know that, you know, such big surgeries definitely impact the quality of life. So let's go with the case now. And, you know, you're an MDT. We don't have a radiation oncologist, but I know there is a radiation oncologist in the audience. So maybe we can call them and have them chime in. And so we have a 48-year-old non-smoker. He has a swelling in the left neck and he has hoarseness of voice. He has a large growth involving the left lateral half of the tongue. Let's call it more than 4 centimeters, extending to the right side. His extrinsic tongue muscles look involved. He has skin induration, extending up to the level of the hyoid bone, and bilateral cervical lymphadenopathy. The biopsy is SCC. CT neck confirms your physical findings. So, you know, the first question I have is, what's your radiological modality of choice? How are you going to stage this patient before you start deciding your treatment plan? And maybe we can start. Do you want to start from this end, maybe? Or the radiation people, whoever.
So, as highlighted in your case presentation, clinical examination has been done, which seems up to date. So we can rely on that. And apart from that, since it is primary of the tongue, we will go with the MRI of the head and neck with contrast. So that is the modality which we use primarily in staging of this sort of cancer in our institute.
In your institute, does anybody do the surgeons, they want to add something else?
It's a fairly advanced carcinoma tongue, and it's extremely important also to rule out any distant metastasis. So MRI, of course, is a imaging of choice when I have to image the local area to figure out, because whatever you have said in your description, coming to the hyoid involvement of the submandibular space, I understand this is in contiguity. That means the carcinoma tongue infiltrating into the floor and coming and invading. This is a unresectable lesion. But then to have a further clarification, whether it is actually the tumor invading or it's an inflammatory process, one needs to work it up on this particular scale. But then, because it's a fairly advanced cancer, I think we should rule out any distant mets before taking a call.
Dr. Kattan?
So I echo the same thing, that large disease, T4B going into the hyoid, you have to rule out your distant metastasis before subjecting them to either a chemotherapy or any treatment what you have. Because the thing is that you are putting the patients either in the palliative treatment or otherwise curative treatment. Curative also is very, very difficult in this scenario, but you will definitely rule out. So MRI, if the patient is already done outside, I'll ask a CT thorax, which can be done to adjunct the findings to rule out distant mets. Otherwise, a PET CT scan would be treatment investigation of choice.
Yeah, I would agree. And I think especially in the oral cavity also, they really emphasize on the point, because these are highly aggressive tumors, that, you know, having your a PET CT would be good. There was this data that showed that, you know, you pick up.
One thing I add in this, because the causative factor is lung cancer and head and neck cancer are almost like the same, like a smoking, gutka chewing and other things, tobacco. So there can be some simultaneously lung primary also there. So if advanced disease patient getting a lot of thing out with this, so of course we'll start with the CT scan, thorax also, or PET scan of whole body.
Right, I totally agree. Field cancerization in these sort of cancers is very, very, well-known etiology. So now we have an MDT and everybody is here. What is going to be your treatment approach? And Dr. Tapaswini already told us she thinks it's unresectable. And would you deem it like never resectable, or would you say, you know, let's do something about it? And anybody else who wants to join our MDT can join.
Yeah, involvement of the hyoid is an unresectable disease. So this patient, he's a 48-year-old, to be given some chance, I think CCRT would be my treatment. I mean, I would obviously discuss him in the the multidisciplinary clinic. And if I were to take a call, I think CCRT.
Okay, Dr. Katnau, do you agree or you don't agree?
Large disease again, I don't think that in future also this patient may be deemed resectable at any point of time, but obviously clinical examination is must. Sometimes it's just a swelling only which is coming down, or it's really a hard induration node which is involving the skin. So the other option which can be tried is induction chemotherapy. But again, I'm wary here a little bit because without seeing the patient physically, but we'll evaluate again, we'll see clinico-radiologically again. If this is the scenario, most probably he'll not come down for surgery anytime. It deems unresectable at this moment. So then palliative CTRT, or otherwise keeping his age, no distant metastasis, 48 years, young, old, you can give an induction chemotherapy because a large volume disease, and then probably follow it with the CTRT.
Yes, and so let's come to
same
medical
thing, yeah.
oncologist.
Yeah, same thing.
Do we
but-
ask Dr. Ankit, is there? Yeah, let's ask him.
Same thing,
I
but
do-
add on over here because the sorry, I lost.
Maybe
Yeah, we just skip through some slides. That is a functional problem in the head and neck cancer. So here, induction chemotherapy can help also to some sort of improve the functionality. That is some sort of pain, immobility, speech therapy, speech, and deglutition or other things. So these things also be improved during the induction chemotherapy, and later on patient easily accepted surgery or concurrent chemotherapy.
Dr.
So,
Ankit, do you want to add on, like, what would be your approach, and maybe talk a little bit about the Tata data on neoadjuvant and borderline resectable, because basically that's something we all need to discuss.
Yeah, I think for this patient, what I will prefer is I'll speak to my radiation oncologist for a radical CTRT. I think that should be what I would like to discuss with our radiation oncologist. I personally feel that giving induction might not be very helpful to for this patient, and radical CTRT should be a better option for us.
So I'll just point out one thing, like we do know that patients with oral cavity who are unable to ever get surgery, their results are pretty dismal. I mean, we're talking about 5 to 6 months, 7 months overall survival. So maybe do the radiation oncologists want to chime in here and say something? Or, oh, ma'am is here. Yeah, great.
Just, I think what I'm saying is very, very provocative, and it's very early. Very early. Thank you so much. What I'm saying is very provocative and very early data. I will be sharing some of our initial experience of proton with unresectable oral cavity cancers. And it's very exciting. It's too early right now to say that this is an option, but it's exciting. And I will be discussing that a bit.
Sounds great. We look forward to hearing that, especially in this subset who does so poorly, as you said. Yes, Dr. Kattan, would you like to say something?
Hello, yeah. So if we look at the Tata's data also that we are talking, Vijay Patil's data, where they have seen borderline unresectable patients, and they found almost like 40% patients underwent surgery after induction chemotherapy. But again, that was a retrospective data. That approach, yes, as we discussed, probably might help in this patient, but not surely because it's a large disease. But again, being a retrospective data, a lot of patients in that data which were deemed unresectable because of infratemporal fossa involvement, tumor going or edema going to the zygoma or to the parotid region, not this much of volume of disease. But yes, that's an option here.
Okay, you were asking about TMH data. Now we have data from TMH Muzaffarpur, which is again sister branch of TMH Varanasi. So there has been data about Peclicarbo, taxane and platinum along with oral metronomic chemotherapy as a induction chemotherapy, and it has shown a very good overall response rate, and we have been able to achieve a response rate of around in the tune of 65 to 70%. So that is very overwhelming. And now we are also have planned a prospective trial for in neoadjuvant setting with this regime, and we have started recruiting the patient. So in the near future, we will have a better data in induction chemotherapy.
Yeah, so that's an important point. And also the another thing that is probably like, as ma'am has given us one option that is upcoming is proton-based therapy. There's also, the immune checkpoint inhibitors being added on into neoadjuvant therapy. And the one thing that I would really put up here is because of the age of the patient, and one of the fallacies I think about living in our country is that we all know triple drug regimen is better than double reg, but most of our patients don't end up getting the triple drug regimen. So I would say that actually this person is somebody that I would try my hardest to, make him at some point, if possible. Medical oncologists always live on hope.
So again, in the last 3 years at Tata Varanasi, we have treated more than 150 patients with DCF. That is a 5-day 5-view protocol. So that data is not available in Indian perspective. So we have analyzed our data, and it was retrospective data was published 1 month back. So in that we again have seen that only 30 to 35% patients have only turned up to be resectable. So that is after full DCF of 5 days. That is the data. So that again, the tolerance is an issue. And again, if already we were treating with the double drug, as you said, or reduced dose 5 if you only 3 drug. But with the 5-day also, we are not able to achieve that significantly improved response rate.
Ma'am, did you want to say something?
Yeah, most of these studies, talk about oral cancers as a whole. Whenever we review our literature, it talks about response of induction chemotherapy in oral cancers, but no one talks according to the subsites. Now, if you see your tongue doesn't behave like a buccal mucosa, or a buccal mucosa and a floor of mouth can't be compared. So I think we need a lot of data to pull in and say that whether it would work in this particular situation. Making an overall view of induction chemotherapy in oral cancers, I don't think it's fair, because all the anatomical subsites in the oral cavity behave very differently.
So induction chemotherapy is a very controversial topic, I would say, because, there's never been, most even medical oncologists are not very gung-ho about the whole thing. So what's where would you use it and where would you not? Like, there a lot of the trials which have even organ preservation are not just, but oral cavity, others also. Let's talk to the medical oncologists. What do you feel about it? Maybe Dr. Ankit would like to start, and then we can go to Dr. Pavan and then Dr. Ankit, is he here? No. He's not here. Dr. Pavan,
Yeah.
yes.
First thing, as we started with a borderline resectable or resectable. So, and a young patient, borderline resectable, skills of surgeon, experience of surgeon say, if you will do something for a chemotherapy, later on we can see. And as the data suggests that some point of time surgery happen. So one of the area where we can do on the institutional basis, and we are using it. And some of the other point, I don't think is a neoadjuvant or induction chemotherapy is a magic. Only just improve the functionality and other things.
Dr. Anuj, did you want to add something?
I agree with Pawan sir, because most of the time we are not very enthusiastic about starting the patient under the neoadjuvant chemotherapy, because at many times we know that the patient is not going to improve. But keeping the thing that patient is young patient, he may tolerate, then we end up in giving neoadjuvant chemotherapy. But again, as I already told in our retrospective analysis, the result have not been that good.
Yes, Dr. Rakesh.
Ma'am, may I ask a question? No, I'm just curious about the induction chemotherapy study that you were talking about. So were these borderline resectable patients? Were these inoperable patients?
These were borderline resectable patients.
Right. So in inoperable patients, that's the critical. See, borderline resectable, I think we all agree after the Tata data that we must put them through neoadjuvant chemotherapy, but it's the inoperables. What is the answer for that?
I think that is really the issue, because we know that these are the patients with either they'll fall into the palliative category, or you're going to do chemoradiation, which doesn't have that good outcomes in the standard chemoradiation, I would say. So I don't know if anybody else has a different take on it.
What I wanted to say was that in that group where it is inoperable, I mean, sometimes do we agree that sometimes adding neoadjuvant chemotherapy might eventually compromise the radiation delivery, or risks progression while on treatment? What is the thought?
I'm not sure if we would call it induction chemotherapy in that palliative, yeah. So,
Can I ask, like Dr. Sapna, many times it's medical oncologists. We know the patient is surgically not suitable for upfront surgery, and the radiation point CT plus RT is recommended. Induction chemotherapy is not recommended in very sort of large studies and positive studies. Many times we have a fear that if somebody is able to tolerate and respond to chemotherapy, probably the same patient will show good response to radiation as well. Am I right in saying that?
well, like bioselection kind of a thing, yeah.
Yes, I do believe that they have a better response. But on the other hand, if a patient progresses, I mean, these are difficult patients. It's not that they have a huge benefit with CTRT either.
Right.
You know.
Sir also wanted to add something?
Hi, I'm Dr. Ankit. By chance, I'm also Dr. Ankit, and I'm a surgeon. So basically, as what discussion was going on, we do not have a head-to-head data comparing in palliative settings upfront CTRT versus chemo followed by CTRT.
Mhm.
Now we have to actually give treatment tailor-made for a patient. For example, this patient which was having a large tongue mass, which was going down into the submandibular region, abutting the hyoid, very close to the skin. If I start chemoradiation immediately, there is a chance that the skin might give way and there might be a fungating wound, after which the radiation might not be completed. In such patients, I would like to give chemo. Again, it is a tailor-made decision for patient in a multidisciplinary meeting where everybody is a stakeholder in the patient's management. Giving chemo in this patient, if he responds well, definitely there will be some shrinkage. Patient high chances might complete chemoradiation. Loco-regionally might have some better control. I won't say it will be a CR, a complete response, but yes, there would be some control.
All of us agree point that this is a difficult patient, and probably given his particular, like that individualizing for this patient, probably doing chemotherapy would be probably the way we also do it. All right, very quickly, maybe one of the medical oncologists, just like my name, because then I wanted to move to the second question. How do you select your patient? Like, who is the patient you will give triplet, and who's the patient you'll give doublet, and who's the patient you will say, no, forget about it?
Deciding about doublet and triplet, that is based on the performance status and the lab parameter. That is the only thing, because we know the response rate and what we are expecting. So
do you routinely do any tests to choose your patient, is my question. Like any things you do before you start off?
But just to look for the chemo fitness, we do that if, for cisplatin eligibility, whether the patient is eligible for 5-FU, we do DYPD testing. That's
okay.
and
No
about the lab
audiometries or anything like
no,
that?
for cisplatin, we do audiometry and creatinine clearance. That.
So did you want to add something? Then we'll go to the next one.
In cardiac workup also, we are using the 5-FU. Otherwise, in younger patient, we use a triplet, and older patient in last 2.5 years, I'm using doublet because of the longer stay in the hospital and COVID era. So using doublet, and I found that doublet and triplet is the same result.
So one of the points that I wanted to bring up, which I was just reviewing, is about the 5-FU really, because all of us are a little scared about the 5-FU. And, we don't do it routinely, but getting that DPD testing done perhaps would be a way for us to pick which is the patient who's going to not have such a difficult time as, because there are a large number of patients, up to 25%, who are heterozygous for that and who may not do well with the 5-FU. So perhaps, although I agree, we don't routinely do it. So that's one thing. Okay, so I'll move to the next case, because clearly the MDT was divided on this one. 68-year-old.
Just a quick point regarding the DPD mutation testing. Our medical oncologist team, they have started doing it in all patients because if you see, it's almost 20 to 25% in Indian population,
Right, 20.
which is a significantly high number.
Right, it's 1 in 4 is going to have a bad outcome
Yeah,
because if you
that's
give
it.
them 5FU, right? So the next case is a 68-year-old diabetic, ex-smoker, history of hypertension. He presents with a rhinophagia. He has a right neck mass, dysphagia. He has drinking water makes him cough slightly. Baseline nephropathy, creatinine is 1.6. On the examination, he has a lesion involving the right arytenoid, AE fold, medial wall of the right PFS with pooling of saliva, overhanging of the vestibular fold. The cord is not fixed. He has a right level 2 lymph node, 2 into 1.5. The skin is uninvolved. It's mobile. It's squamous cell carcinoma. This is a CT scan. There is a mass involving the right vestibular fold. We can see over here arytenoid AE fold. I agree, this is not my case. This is one of the head and neck surgeon's case. Erosion of the inner cortex of the thyroid cartilage with possibility of minor extralaryngeal spread, but it's not going through and through, and a solitary lymph node. CT thorax is negative for distant mets. Let's talk about our MDT's treatment approach.
I think refer this case to Dr. Sapna Nangia for proton therapy. The perfect case for the.
So,
Okay, so this is early T4A disease because the inner cord, the cartilage of the thyroid is only eroded. There is no major exolaryngeal spread. Though I would like to have some more images and preferably an MRI in this patient to see if there is an exolaryngeal spread, because then it will convert into a T4A, which will be subjected to surgery. This patient also has vocal cord paralysis, probably because he's coughing.
So actually, I want to bring up that point.
Yeah.
What testing, because I know the surgeons always do it. What tests do you do for looking at,
So we do in a fiber optic scopy or on a Hopkins examination and our OPD setups to see for the vocal cord. If the patient is gasping more, then we do on a fiber optic to see for the aspiration, and simultaneously you can do a FEES also to see whether the patient is aspirating at that moment. So you come to know that how much the laryngeal function has been deranged at that point.
So when would you not send your patient for radiation is my question.
No, so this patient, looking at his scans plus the laryngeal function is gone, probably he'll come for the surgery. That will be total laryngectomy for him.
All right, ma'am, Dr. Tapaswini.
Yeah, the catch is you have to assess the dynamicity of the organ. It is not just cartilage erosion, minimal erosion, or, so you have to assess the functionality. And the two functions which we are looking into, one is, of course, the swallowing function and the functionality of protective function of the larynx. Aspiration, as you said, and you said the cord is mobile. I don't know whether this reading was correct or not, because if the cord was mobile, then in that situation, a tumor sitting on the arytenoid, pooling of saliva happening, and the arytenoid not getting disturbed, not causing any fixation. I mean, it's a chance sort of a thing, such a big tumor which has filled up the PFS, starting from the arytenoid and AE4, not causing fixation. Probably they might have been a fixation
So
in
actually,
that.
coming back, because this is an actual patient, he didn't have it because initially on history, they thought he would have it. Like he
Okay.
would not be a candidate for radiation, but his swallowing function and he was not aspirating when they did the tests.
Okay. So
Are we
if
done?
it is a functional, so basically the treatment, whenever you decide the treatment in these situations, if it's a functional larynx where you feel that this organ can be preserved, it is T3,
T3.
may go into T4, which is not really very clear. Maybe some imaging would work. In that situation, one could look into a neoadjuvant and assess him for the next course of treatment. But if the functionality of the organ is disturbed, when you do a functional assessment, then this patient should be going outright for a total laryngectomy.
Dr. Sapna, did you want to say something about
I would agree with
Dr. Tapaswini?
If only the inner cortex of the cartilage of the thyroid cartilage was infiltrated, that would not be a contraindication. However, functionality would be very, very important.
Correct. Yeah, I think all of us agree that that would be the deciding factor where this patient would land up with the surgeons or the radiation oncologists. And I found this paper, I mean, most of you are probably familiar, and it was very, the recommendations that they give was very apt. And they also said that there will always be some patients who have even if they have the large tumors, even if you do organ preservation, you will not achieve the results that you are wanting. So then it is better to go for, that was something that I didn't think of usually in that, because all of us are always, we want to do the organ preservation. But sometimes with the large tumors, that may or may not be possible.
So volume of the tumor is another, you know, if the volume, I think if it exceeds more than 30 centimeters square, something, in that situation also, these are candidates for surgery and not for organ preservation.
So coming to a medical oncologist, suppose this patient is a candidate for chemoradiation. What chemotherapy with a compromised renal function are you going to select? And this is an elderly patient who's, I think he was a diabetic and hypertensive and everything, you know.
I think carboplatin, concurrent carboplatin is enough. Otherwise, we can use nivolumab in Indian setting also with the carboplatin. And of course, cetuximab is again there.
Okay, I just quickly, this was presented in ASCO this year actually, where they talked about, do you want to talk about it, Dr. Anuj?
Actually, in this, docetaxel was compared with placebo. So the comparator arm in that was not there. And also it showed a very good DFS, and also the toxicities was also increased. Grade 3 toxicities were in tune of 50%, and all grade toxicities were in grade of 85%. So this is an alternative we can use.
There's also a looking at docetaxel cetuximab versus cisplatin cetuximab also. There is a weekly study I saw.
So I'm not actually aware.
Okay, no, that's fine. So your choice would be, if you had to pick one. Dr. Pavan already chose carbo, I think. Or cetuximab if the patient is a
patient is cachexic also as per the your case. So I will go also like to go with the carboplatin only.
Okay. And anybody for using nimotuzumab with?
Nimotuzumab can be added if the patient is affordable, but single agent we are not using.
Okay. Ma'am wanted to say something.
I mean, I think it became very clear that, you know, the general impression used to be that cetuximab may be used in elderly, and actually there is a contrary view to that cetuximab should actually be avoided in the elderly. And I have to mention that we have used nimotuzumab alone for some of our elderly patients. I'm not sure whether we are using it for our satisfaction, that we are intervening, but it seems to be so far at least tolerated all right, is all I can say.
I totally agree with you, ma'am, where initially we used to think of cetuximab as an option for the poor PS, but it's not an option for the poor PS. It's only an option for the good PS who cannot get cisplatin because
and has poorer results than cisplatin. Now there are multiple studies telling us.
I agree totally.
But alone need to
cisplatin ineligible patients accept docetaxel with concurrent radiation. Any regimen? Carboplatin, cetuximab, any?
So I'm not sure if it shows a benefit in OS, but there are only 2 category 1 recommendations. One is cisplatin.
That is the NCCN we are talking about, category 1, and it may take time to come in NCCN also. But the thing is, it is not dependent on NCCN. If we go with NCCN, then nimotuzumab is always out.
Okay, so we leave it at that controversial point, right? Yes, thank you. So I really want to thank everyone and thank our audience also for participating. So thank you very much.